how can we improve? We're always looking at how do we do better? How can we engage people better? And what does that look like? So we're always going back and retraining and learning from our mistakes and learning from the mistakes of our colleagues, right? Like, how can I share my experience so somebody else doesn't step on that same hornet's nest next time? We just had our TCM audit, and how do we grow from that? How do we improve our care? We don't look at it as a bad thing. We look at it as a way to grow, because we're not perfect and we're not going to be, and we always have room to improve.
Today on the Move to Value podcast, we continue our conversation with Julie Quisenberry, Director of Care Integration at Coastal Horizons, to talk about care management at the front lines. Julie shares what it really takes to deliver whole-person care, meeting people where they are, overcoming language barriers, addressing housing and food insecurity, and navigating a constantly shifting system. She talks about what it really means to support people beyond the clinic, with a real-world look at the challenges and the small wins that make all the difference. Well, Julie, thanks for sticking around for the Move to Value podcast. I'd like to ask you some more questions, but I'd like to start with the population about what Coastal Horizons serves. What unique needs do you see, and how does care management address these needs in ways that traditional models don't? And are there specific challenges, social determinants, housing, trauma, chronic conditions that require a more tailored approach?
Yeah, so Coastal, again, is a very large substance use behavioral health provider. One of the things that we have that we are fortunate to have is we have our Clinica Latina program that does outpatient and is geared toward our Spanish-speaking population. Therapists, we have psych providers, MAs, and in our primary care practice, we also have Spanish-speaking provider and Spanish-speaking MAs and front desk staff, because we've seen a large influx of that population reaching out and accessing care, which historically, I think in the behavioral health sense, has not been something that they have done. So our Clinical Latina program started out very small, probably about 15 years ago, and has grown to almost tripled the size, which is great, and we want to embrace that. And they send, in primary care, send a lot of folks to us because they've gone without healthcare, and so we have grown. That has grown for us in primary care over the last 2 years since I've been doing primary care. Has grown a lot, and so the need for bilingual folks has really grown. So we're really fortunate to have that, and even in our kid population, expanding our reach with bilingual therapists and bilingual psych providers as well. So I think that we've really tried that. We will serve anybody regardless of language, because we do utilize the language line. So just trying to make sure that, that's probably been the largest population that's grown. We serve, listen, we are non-judgmental, whatever your need is, come as you are and we'll figure it out, right? So I think that, and if we can't do it, then we have community partners that we can refer to. Like if someone has a significant or severe eating disorder, we may refer them to Chrysalis Center, that's their specialty, right? In primary care, we have taken on, we've expanded our Hep C treatment program. So we have some primary care providers that are sending folks just to us for Hep C treatment. And then we refer them back to their primary care once, kind of like your OBGYN. You have your baby and then you go back to your primary care. We kind of do that in primary care with Hep C and have grown our Hep C programs because, with the opioid addiction and, IV drug use, it's just, New Hanover County is just like, I don't know what the right word is, but it's overwhelming sometimes, the volume of patients that we see. We have a very large medicated assisted treatment program as well that sees those folks. So we collaborate to ensure that they get their physical health and behavioral health. Social determinants of health are a big deal. As you're probably aware, the Healthy Opportunities pilot ended. We were fortunate enough to be part of that, and we're able to serve over 400 clients a month in housing navigation, first month's rent and security deposit, healthy food boxes, interpersonal violence, utility assistance, all the things that program kind of encompassed, and the loss of that as of July 1 or June 30th. Is significant for us. So we're having to be more creative in how we help people access those services, because affordable housing in our area is just really, really hard. It's not affordable. I mean, it just isn't. I look at people that I know that aren't struggling with any kind of, I don't want to say disability because that's the wrong word, any kind of issue or struggling, and making $10 an hour can't live here. They just can't. And so we have a very large homeless population. Coastal is fortunate that we have our PATH outreach and our port outreach that specifically work with our homeless population and try to house them. But social determinants of health, we're utilizing like the food banks, we're utilizing Nourish NC, our Wilmington Health Access for Teens, has given out more food boxes, 30-pound food boxes, since the end of Healthy Opportunities than it did in the last 6 months of the year. So I'm really sad about that. And I hate that, but I understand the logic. If I were a senator and my constituents weren't benefiting from this very incredible program, why would I vote yes? I vote yes because it's in my area, but it can certainly appreciate the dilemma that created in Raleigh, right? Like, can certainly appreciate that. Hopefully they'll revisit that because it has significant benefits to people. It decreases, it's a non-medical intervention, if you will, to meet people's basic needs, keeps them out of the hospital, keeps them from going inpatient, keeps them from doing all the things. So we're doing the best we can around that, but it was a struggle. We're still kind of working through what does that look like and where do we get rent and where do we get people housed. So, but we're using what we have in our community, and our community is trying to embrace that, the loss of that service. But it's been a difficult transition for us, just our care managers in general. So I guess that's what I would have to say about that.
Yeah, it's been tough in a lot of the places where cost of living is much higher, and we've seen that.
Yeah.
And I know that New Hanover, Wrightsville Beach and Wilmington, it's expensive. Coastal towns typically are expensive. So,
and if you move to Brunswick or Pender counties, then you lack transportation to get into where the resources are. So it's this double-edged sword of, you can move to Pender County if you want, but you can live in Burgaw, which will take you 25 minutes to get here, 30 minutes to get here, and depending on the day with traffic, could take you even longer. But how do you get here? We have mobile clinics that do Bladen and Columbus County and Southern Brunswick County that are doing primary care and behavioral health and substance use services, because the outreach and the need is there. But it's hard because the resources aren't there. We can do all the things, but the resources just aren't there. So it's tough.
Well, in the context of tailored plans, what are the biggest gaps you're trying to close, and how are you doing that? I mean, we've talked about physical and mental health and community support and clinical treatment. What are some of the gaps that are there you guys are working on?
I think one of our biggest gaps, the one that comes to mind right now with my tailored plan care managers, is finding a Medicaid dentist for adults. Has been really difficult in our area. We're referring like to ECU and other places. That's been one, and that just comes up because we had a conversation about it yesterday. So I think that's the biggest gap that we're seeing. We are housing, obviously, we just talked in ad nauseum about housing is a big gap for our folks and being able to be housed. I think closing the gaps is just really looking at what somebody needs and how do we get there. Obviously, everybody needs an annual physical, so we're working on those healthcare gaps. Annual dental or every 6 months, but we got to find a dentist first. Kids is a little bit easier because we do have pediatric dentists that take Medicaid. But I think sometimes too, the other gap that I see, and I think this is true for the standard plan as well as it is for the Taylor plan, because on the Taylor plan, we are an AMH plus as well as a CMA, which means because we were on the standard plan side as an AMH tier 3. So we have this weird hybrid. I think we're one of only 3 in this state that do both. Transportation is another one. Trying to find transportation, Medicaid transportation that's reliable. And I can't remember the other one because it's true on the standard plan side as much as it is on the primary care side. But it'll come back to me probably at 2:00 in the morning.
Perfect. Just give me a call.
There you go.
I'm always awake. Well, so earlier we spoke about some language barriers and how you guys are successfully overcoming those. So how do you ensure that the care management services are equitable, especially for systemic barriers? And we talked about language, but what about cultural, systemic trust? Are there strategies for outreach or adaptations that have made a difference there?
Yeah, I mean, I think we have Spanish-speaking care managers as well. I talked about it with our, Clinical Latina. We have it with our primary care, but we have Spanish-speaking care managers as well, and we have a Spanish-speaking community health worker / extender. And so we do a lot of our director of care management, I will say, is probably, I think cultural competency is something that we all are working on every day, right? But she's probably one of the most culturally competent people that I have ever come across in my professional career, in terms of really being mindful of, you can't just assume that because someone is a certain way, looks a certain way, speaks a certain language, that you understand the culture. And so I think she does a lot of training around that. And she's had our Spanish-speaking care managers do training with our team as a whole around what does that look like? Because you are kind of there is a very large difference in how they view behavioral health services versus how we view it. And so we've done some training around that. We, try to have really open door policy when someone is struggling with what does that look like? What do I need to do different? Reaching out to our colleagues within our system that somebody may have had experience working with someone who is, first generation. We just had this happen, someone who's first generation from Korea, and trying to navigate just our system, as well as trying to navigate the language barrier and all of the things. And what does that look like? Then there's the educational piece, is, are we giving people things that they can read? Do people know how to read? I sat in the lobby last week and went through our consent forms with someone, because they were humble enough to tell me as I was walking through. I said, "Hey, how are things going?" And they kind of looked at me. I said, "Well, what's going on?" And sat down, and were humble enough to tell me that they couldn't read it. So our front desk handed somebody a packet of paper to fill out without even, and this human sat down and just sat there. And I'm like, I just happened to be blowing through on my way to my office. And so I think we have to just sometimes take a step back and remember that, are we giving people things? Are we asking the right questions? Are we doing things in a way that makes sense? And we, like I said, I think we always have room to grow in that area. We are never going to be perfect at that. And we are going to fall into the pitfalls, because it's human nature, right? And we live in our space and they live in theirs, but how do we work in that space where there's mutual respect and mutual understanding and respecting whatever that is? We had a care manager come in, and they went into a house, and the mom asked her to take her shoes off, and she didn't want to take her shoes off. Well, that's their home. You're walking into someone's home, and having those hard conversations of, that's what they expect you to come in your home. And so how do we work through that? And so I think we take it as it comes, and we do the best that we can, and are always mindful. And like I said, our director does a really good job of trying to make sure that she's always talking about that. People don't look like the same. People don't always look like you. They may, but they may act very differently. Their home life, everybody comes to the table with whatever their life brings them and their life circumstances bring them. And we have to remember that while we bring those, so does every single person. And we always work from a trauma-focused perspective, because whether you choose to believe it or not, everybody's had some sort of trauma in their life. Myself, you, everyone. And so we kind of always work from a trauma-focused lens, whether they choose to share what that is. But you can use the skill set that with being trauma-informed. And we train in that, and we train around that. Whether someone chooses to disclose what that is or not, you can use that lens by which to work from, and then always coming at it from using motivational interviewing to get folks to engage with you. So we do a lot of training around that. So we just we're always, how can we improve? We're always looking at, how do we do better? How can we engage people better? And what does that look like? So we're always going back and retraining and learning from our mistakes, and learning from the mistakes of our colleagues, right? Like, how can I share my experience so somebody else doesn't step on that same hornet's nest next time? So we do a lot of that, and we believe that we just had our TCM audit, and how do we grow from that? How do we improve our care? We don't look at it as a bad thing. We look at it as a way to grow, because we're not perfect and we're not going to be, and we always have room to improve. So that's a very long answer to your question.
No, that's a great answer. And I think this podcast is one of those mechanisms for sharing that information so that we can all learn from each other. You know, my family's been generations here, and I've worked in healthcare for 10 years, and I still don't know how to fill out the forms. So right. I have great sympathy for some of the folks who do come here, their first generation, and we see a lot of the kids helping their parents, you know, translate the forms, and it's a challenge. And I hope that I'm glad that you over at Coastal, you guys are really taking that initiative, because I do think that's so important.
Yeah, most of our paperwork is in Spanish, is when you get the one-off languages that we don't necessarily have. All of our paperwork is in Spanish and in English. So, but it was a good opportunity. Like I said, when I blew through last week, it was a good opportunity for us to retrain our front desk, and not assuming that you hand somebody the packet to fill out and that they're just going to go sit down and fill it out. It's asking the next question, like, hey, do you have any questions about the paperwork? Is there anything that you would need assistance with? Just let us know. And somebody may or may not ask. But you could see the look on this person's face was just like, I knew the minute I walked through, I knew that there was something going on. So it was a good opportunity for us to go back and retrain people and paying attention to the social cues, because sometimes it's the nonverbal as much as it is the verbal. Right? So it was a good opportunity and a good learning experience for us. So we're always going to try and do better.
That's great. Well, where have you seen wins, like improved outcomes, better engagement, smoother workflows, and what are the friction points? So what's the good and the bad and that you're tackling? Is it staffing, integration, follow through, or is it something else for that one?
So I think we have lots of wins every day, right? Lots of wins. Somebody gets their own house. Somebody gets accepted by Habitat for Humanity. Somebody decides today is the day that I'm going to walk into Coastal and I'm going to engage in treatment. Somebody decides today that, you know what, I'm ready to go and have the physical. So we take the wins as they come, and it's not looking for the big wins. It's also looking for the small wins, because the small wins are the ones that make the biggest difference in the long run, right? So we see those every day. Our care managers, we celebrate our wins in our monthly staff meetings. So we ask people to share the wins that they've had, so that people can, because this job is hard on a good day and it really sucks on a bad day, right? Like, because of the, it just does. And so we take the wins and we like to share the wins and we like to celebrate the wins. So we have a Teams chat that people put in daily, like, hey, guess what? So we celebrate those. I think for us, the friction points have been around the constant change in the provider manual, the expectations of TCM. I think that when most of us signed up to do this, the vision was one thing, and now we're like way over here, and the vision is something that's incredibly different. We have, I won't say we've embraced the change, because it's been hard, but we rolled with the change. But I think that's the hardest part, is there's always something new that is being tacked on to care management that wasn't intended to be part of care. 1959 is a perfect example of that. That's tacked onto it, that creates this whole other workflow that nobody understands, that it's a lot of work, and it involves multi-layers of people and stuff that we're expected to do. It's just the constant change. And I think that's the friction point for us. We work through those changes, we implement those changes, and then some other change comes along. If you've been around in community mental health for any period of time, you kind of know that that's what's going to happen. And I'm old and I've been around for a long time, so I do know that that's what's going to happen. But what I will say is I can tell you that honestly, I don't know that I've seen a provider manual or a clinical coverage policy change as much as the TCM provider manual has changed. Most services in our space have a 5-page clinical coverage policy. We have a 85-page provider manual. So again, I think it's that's been the point of friction for us, is how do we, because once you think you've got it, then something changes. And then we have to come back to you all and say, hey, Denise, guess what? We've got to change the health assessment, or can we add this block, or can you put a check mark in? How do we make this work? So I think that for us has probably been the biggest friction point. But like I said, we believe in the service. We believe in helping. We believe that we can do it better than the LME MCOs, even though they would say something very different on your podcast. But I think there's room for both of us to do it and do it well.
I agree. What advice would you give leaders trying to build or improve care management systems in other communities? What do you wish you had known? What are key partners, cultural shifts, infrastructure elements that make the difference, and what can go wrong?
Yeah, I mean, I think the biggest advice I would give is you have to roll with the changes, because what you think you know today, you're not going to know tomorrow. And I think it's the nature of this service. That's hard. Change is hard, right? And so just when you have 10 care managers and they all think they got it, and here we come and say, guess what, y'all? We told you, that you were going to do this, and now you're going to do that. I think communication for us has been the key. Of really communicating with our team, being transparent with our teams around, and not, just handing somebody a provider manual, but those monthly meetings where we're sharing updates has been helpful. I will say again, celebrating the little wins, because again, this job is hard on a good day and sucks on a bad day. And so celebrating the little wins with people and really celebrating people's successes, both personally and professionally, because we had one of our extenders just got certified as a community health worker. Let's celebrate that, right? That's a personal win for her, and that's a professional win for her. So what people are willing to share, and how do we do that to building a really cohesive team? I think the pitfalls are getting sucked into some of the stuff when you get on the state tag meetings or whatever. And I've told there was all this stuff around the rate and all the things. And I hear that and I appreciate that. But I can tell you that you have to pick your battles. What sword are you willing to die on? And so that's what we have at Coastal has decided to, here's what we're willing to argue for. Here's what we're not willing to argue for. And then I have buy-in. I'm fortunate enough that I have buy-in from my leadership, that our COO and our president and CEO have bought into the service, and bought into how the service helps everyone at Coastal. Like if they're working with a psychiatric provider or a therapist, that really has been, I think, instrumental in us being able to grow our team the way that we did. And so we're really lucky in that regard, to be able to build that. So I think, for me, it really is celebrating the little wins, communicating, and really building a culture of trust with your care managers, and a sense of team and camaraderie that they can ask one another questions. And then from a leadership perspective is getting buy-in from your leadership. Why is this service important? How is this service going to benefit our other programs? And if you have that, then I think you can have a successful program.
Buy-in seems pretty easy for me. I mean, I don't see how you couldn't, because of the difference that it makes. So,
yeah, it does.
I'm going to give you a blank check and full freedom to redesign care management from the ground up. What would you build or invest in to make a system that's more humane, efficient, or scalable?
That's a loaded question. I don't know. I need to think about that. As my bosses, I want to give you my best answer, not my first answer. But if I have to give you my first answer, what I would say is that if I had to do it again, and we could build it from the bottom up, the collaboration in building the service needs to start with providers, the tailored plans, and the state all at the same table, and developing a service where there is room for everybody, and that one group or the other isn't driving the bus, that everybody has a seat on the bus and the driver is some independent person, because I think that everybody is motivated by their own roles in this, and the design initially was that the state was driving the bus, and then the LME MCOs kind of come over and then they start driving the bus, and then the providers have their version and they're driving a different bus. So it's getting everybody on the same page and building it from the beginning about what the expectation of the service is, and then let's stay with what that expectation is. Let's not keep adding things onto it because, oh, we've got care management, we can just add that to it, which is what it feels like has happened. And that doesn't work. You can't ask people to do more with less, right? But let's make it a realistic service that benefits everybody. And they're using the model, ironically. My colleagues at Task, because we have a very large presence in the juvenile justice and task system, they're talking about using the TCM model for Task. Well, somebody in the justice system needs to understand what TCM looks like, because that doesn't translate to this group. So I think if I could build it up, it would be communication. It would be everyone having a seat at the table and an equal voice at the table.
That would be nice. Well, Julie Quisenberry, thank you for joining us today on the Move to Value podcast.
Well, thank you for having me.
This has been the Move to Value podcast, where we explore the people, ideas, and innovations driving value-based care forward. We hope you enjoyed this episode. Whether you're on the front lines of transformation or just getting started on the path to value, this is your place to learn, connect, and move the conversation forward. To explore this and other episodes, visit movetovaluepodcast.com. If you'd like to stay informed about the latest in value-based care, be sure to subscribe to the podcast on your favorite platform and sign up for email updates on our website. If you're enjoying the podcast, please share it and leave a rating or review. Thanks for listening.